Okay, we are back once again with another episode of Claims Denied. Today, super excited to be joined by Tim Elliott over at Navvis Healthcare. Tim, how are you doing today?
Doing great, Blake. Thank you for having me on. Very excited about this conversation.
Yeah, and thank you as well. I know, you guys have been in the value-based care industry for quite some time and have worked with a number of health systems and partners over the years. So really excited to dive into today's conversation. And maybe the first place we can start is really with your career, how you found yourself in healthcare, and kind of walk me through the arc of where you are today.
Yeah, thanks, Blake. I started my career in the banking industry, not the investment banking industry, but the banking industry, and then went back to law school. And my goal at that point in my life was to be an M&A lawyer. That's where I was headed. So after I graduated, I went to work at McDermott, Will & Emery in Chicago in their corporate department. But the floor I sat right next to a healthcare partner. And so I ended up doing a lot of healthcare related activities. And my mother was a nurse. My sister's a professor of physical therapy. My wife's an optometrist. One of my sisters-in-law is a nurse. And finally, I'm like, maybe there's a message being sent here to me. So worked in big law for a period of time, and then supported predecessors to the Navvis organization as outside counsel, then came in-house. And then about 10 years ago was one of the founding groups for the current version of Navvis and moved out of running the legal department over onto the business side and now serve as the CEO of Navvis. And it's been an interesting journey for me. One of the things that I have really observed as I started my progression was I knew from the very beginning I didn't want to be a litigator, that I wanted to be involved in the business side. And being a healthcare lawyer, it's interesting in that healthcare lawyers, unique from other outside counsel, are really called on to help consult and develop strategy and then execute that. So that really set my mind to why I wanted to move over to the business side and away from law. And I've done kind of every kind of transaction you could think about, and it's given me an interesting perspective on why some deals and why some companies succeed and others fail. And it's really informed my conviction and the Navvis conviction around the importance of the physician enterprise. It's not the only thing, but it's really kind of the linchpin, I think, in sustainable change and performance for organizations. You're not going to get there without bringing the physicians along.
Absolutely. Absolutely. And thanks for that overview. And would love to dive into Navvis, but first, can't help but ask, just from somebody who's got a great background in legal and law and healthcare compliance and all those things, I'm curious, how you see, the role of that lawyer in driving forward innovation and change and those sorts of things versus saying, no, let's not take those risks, and kind of how you balance that. I'm curious for your perspective.
You're asking a really astute question, because as I made that transition, it was kind of unlearning some things that I had practiced for so many years, because I was that person in the room, like saying, what about, or have you thought of, and kind of leaving that behind to be the person that's saying, okay, that's not where I'm going to start. I want to start, what do we want to achieve? What are the goals? Am I thinking broad enough about opportunities that we have, strategies that we should be pursuing? And in all honesty, Blake, that was one of the things that was really attractive to me, to move from the naysayer in the room to the one who's kind of driving and pushing the strategy for the organization. Still have to listen to those folks. I can appreciate it, and it's always in the back of my mind, but it is something that I've tried to unlearn a little bit as I've moved from being the lawyer to being the business lead.
Yeah, that's so interesting. I feel like so often with health systems, it's not a let's do this and figure it out. It has compliance passed on it first kind of thing. So yeah, that's where the genesis of that questions come from. It's just, how do we spur innovation with, all departments of the health system, right?
It's tough, right? There's a lot of risk in healthcare. There's a lot of regulation around it, but even when I was practicing law, I tried to be one of those lawyers that would say, how can we do it? Maybe we understanding what the goal was, maybe we can tweak things this way or that way to keep us compliant, keep us on solid ground, but still achieve the business objective.
Yeah. Yeah. That's a great balance. I love that a lot. Okay. Awesome backgrounds. Talked about Navvis. How about you? Could you just give me a brief history of Navvis? Like, what do you guys believe in? Who do you work with? Everything in between. Would love to just hear it from you.
So I'll start with just kind of the complexion of the company and then maybe follow on with some of the things that we are deeply convicted about. So we operate currently in 13 markets. We support about 3 million value-based lives. Through those different relationships, we're working with about 4,600 physicians. So think about SSM, a key customer for us in their 3 markets of St. Louis, Wisconsin, and Oklahoma. But we work with the Tufts organization. We are working with the Hackensack folks around their team model. We work with the Florida Medical Clinic folks in Tampa, doing work with Denver Health Plan. We've supported HMSA, the single state blues plan in Hawaii. So to give you kind of a geographic complexion of what we do, if you think about truly the business that we're involved in, it's really driving performance for our customers. And that catchphrase has evolved a little bit for us over time, even though I don't feel like our core competency has evolved. But it used to be, you heard a lot about value-based enablement, and we still use that term. But I think it's more about driving performance now. So with our customers, we work across all their different payment models, whether it's commercial, Medicare Advantage, full risk, MSSP, ACO, Medicaid. We're not focused purely on a payment model. And that goes to our philosophy of needing to really work with the enterprise and across the enterprise to drive sustainable change. So you go and talk to a physician about their 50 United Healthcare MA patients, it's hard to get their attention. You go to talk to them about their patients who are in all these different payment models, then you start to understand that, oh, maybe we should rethink the way we run our morning huddles. What are we doing from a pre-visit planning perspective? So that's kind of an overview of the business, supporting performance across any kind of contract where there's an element of risk, whether it be just quality or full total cost of care risk, working with our partners to drive that performance.
Yeah, that's a great overview. And it's so interesting you talk about that shift from kind of value-based care to more broadly performance, like optimal performance, and more uniquely to you guys is from what you said earlier around, you really believe that change starts with the physician. And so I'm curious, from a broader kind of macro perspective, given you talked about that shift, how would you kind of assess the overall state of value-based care, maybe how it's evolved over the last few years, especially kind of, post-pandemic and all of that? What are your partners saying?
Interesting question. One, I would say value-based care is an interesting term. And with no common definition really around it, other people are like, well, what does that really mean from a value? When you say value, what's that really mean? It also had a tendency for organizations to think, well, okay, in this part of the world, I have to think about value-based care. And in this part of the world, I have fee-for-service patients. And they viewed it as two separate things, which I think has led to a lot of inefficiency, a lack of performance, and confusion among people. So I would start by answering your question, Blake. That's why you heard me talk about performance. I think that's a clearer way to get at all the concepts that are there around value-based care. We used to start conversations with people who say, oh, Navvis, we're a value-based care enablement company. And they would say, well, we're not interested in that. But you know what? We have a problem with our physicians not being aligned with our managed care contracts. We have a problem with our transitions of care into a post-acute setting, and our patients spend too long there. We have a problem of really impacting the cost of care. And we're kind of like, well, that's what value-based care meant to us. So I think it's starting to talk about and getting at the underlying aspects of what was really meant by or the result from value-based care. So I think focusing on performance and the use of that word, I think provides much more clarity to people.
Yeah, and it comes back to kind of what you were saying around, how do you define value, right? And I've talked to a number of folks who've said, value-based care, like the essence of it is still alive. And so it's almost this shift from, the value-based care, which has become this buzzword for risk versus like high value care, and kind of how you would say describe performance in my mind. So it's fascinating to hear that from you as well. I'd love to get a little more tactical with you around like what does that performance mean, right? Especially within health systems, it seems that lately a lot of health systems have maybe deprioritized quote unquote value-based care efforts, but they still care about performance across their service lines, obviously. So how has your business and your strategy evolved to meet the needs of, health systems, and how would you kind of determine that, I guess, if that makes sense?
Yeah, the thing I would say, Blake, is we've matured along with the market. And at first we were very focused just on those value-based contracts. And then there's no doubt we live in a hybrid world, right? Between value contracts and fee for service. And what we said as an organization, we have to embrace that model, that there's nothing wrong with volume related activity if it's the right volume related activity. And I don't think value-based care and fee-for-service care exist in two different worlds. Let me give you a great example. We had a customer we were working with that we started to analyze all of their inpatient admissions. And we determined that they lost a material amount of money on every CHF admission. And I want to be careful. You have to be attuned to the financials. One of the reasons that it was not margin accretive to them was all of the ancillary cost around those patients and how hard it was to get them discharged to an appropriate next level of care. So what we did, which is very much a value-based care concept, is we developed a program around their CHF patients to identify them in the physician visits, proactively reach out to them in between the physician visit, do everything we can to help them manage their disease outside of the context of the four walls of the hospital. Now, there wasn't a value-based contract rewarding the hospital on the other side of that for that performance, but there was margin improvement because they now had beds that weren't being filled with CHF patients, but were opening up to other patients. So that's I think a really good example of how you have kind of this Venn diagram of where fee-for-service and value-based care overlaps. And that overlap is bigger, I think, than a lot of people think about.
Yeah, that's so interesting. And it's really funny how much of it comes down to financing and reimbursement versus actually treatment of the patient, right? Like that's what should be optimized for. And then the results for doing a good job should be financial reward, right? And at least in my opinion, I know maybe some people would differ on that. So your comments just spurred another question for me, which I'm just super curious about. And I'm curious, like from Navvis's perspective, let's say you onboard a new health system partner to talk about, hey, we want to optimize everything, full risk spectrum, capitation to, fee-for-service commercial, whatever it is. Can you give me some examples of like some things you would look at first, or what are some common things health systems are getting wrong today or need optimized, like those sorts of common pain points?
Sure. Let me give you a couple examples. The first thing that we always do is we look at their existing payer contracts and we say, are you leaving money on the table underneath those agreements? And surprisingly, a lot of organizations are. You have in large health systems, you may have a group that's negotiating the payer contracts that sits relatively distinct from the operational side of the health system and the physician enterprise part of the health system. So we may negotiate very attractive, even just quality incentives within your contract. But if the operations aren't informed around that and the physicians aren't aligned to that, you aren't going to perform. So kind of an initial value add we bring is that quick contract review, identify if there's something that right now, without having to change your contracts, but just through some operational focus, that there could be value created. So that's almost always step one for us. The other thing that we have really found is there is a lot of efficiency to be gained in what people call their care management function. I don't even like using the term care management because it's kind of like value-based care. It has, whoever you ask, it has a different meaning to. But what we found is that a lot of organizations have a diffuse group of people that fit under that category. They aren't working on a common set of interventions or a common set of workflows. There may be duplicate calls that are being made to patients because it's not coordinated. So a next level for us is to really think about the care management enterprise and what does that look like, getting it organized, identifying the folks, getting them on a common set of goals, and then also thinking about the skill sets of those people. There's an aspect of closing gaps in care that's very important from a quality perspective, but there's also much more that can be done rather than just kind of somewhat checking those boxes around gap closure. We think that there's a care management 2.0 that most organizations need to think about and rethink what may be an RN heavy care management workforce to maybe have community health workers involved. Clearly a team that you've heard a lot about in what you do that involves a pharmacist. It involves a social worker. And so that mentality of a multidisciplinary team that really is serving in kind of a care management or patient support function, that's a lot of organizations still need that transformation. And that's almost always part of our work as well.
Yeah, that's so interesting. I think maybe that's the first time I've heard of kind of care management 2.0, but it makes a lot of sense. And I'm curious, like from the the health system standpoint, how do you unlock that for them? Like, what are the steps you take? And also, I'm curious around like what technologically you need as well, and maybe from a like infrastructure standpoint, what do you need first in order to enable that multidisciplinary approach?
Yeah, let me work backwards on that. It's so many of the health systems today are on Epic, and Epic does a lot of things very good. But one thing that it does is it's a common platform across the health system. So we've really we developed a lot of Epic expertise within our organization to help build those workflows into Epic. So when the care manager is using the Epic platform, the physician can see that and vice versa. So there was a point in time years ago where we kind of fought that and said, oh, we white label technology. We aren't a technology company, but we really said, oh, you need to be using our platform. And then as we matured in our thinking, we said, no, let's not create that abrasion with the physician or with our partner. So from a technology standpoint, when we start out in a relationship, our goal is to try to optimize any technology that currently exists. We do that for two reasons. One, that money's already been spent by our partner, and we really don't want to make that our transformation any more expensive. The other is there's such switching cost when you move from one platform to another. Not only the financial aspect of it, but you have to recreate the data feeds. You have to retest the data. So from our perspective, that's probably delaying our ability to impact cost and quality with our partner by at least 12 months. So our goal is to optimize what they have. If there's a shortfall there, we will call it out. We've done a lot of analysis around here's holes that we think you have, and here's how we can fill those. But from a technology perspective, a lot of these technologies are blamed for lack of performance. That relates back to data not going in correctly. It relates back to people not fully understanding the platforms. So investing on our side to provide that insight into data ingestion and then ultimately use of the platform has been really valuable for our customers as well.
All right, folks, you hear that? Navvis says to do your blocking and tackling in healthcare. It's very important. Okay, maybe we could dive more tactically into. You mentioned SSM earlier, and talk a lot about physician alignments, and the physician enterprise is so important when it comes to value-based care and care coordination and performance, I should say, rather than value-based care, since that's what we're talking about. Can you talk to me around that partnership? What did real change look like inside the physician enterprise? Maybe some parts you weren't expecting to be hard that were hard, and vice versa. Walk me through that.
SSM's been a great partner for us. They came to us and internally had done kind of a buy or build or partner analysis around value-based care. They knew that they wanted it to be a core tenet of their business going forward. And as they thought about it, and their different executives brought experience from other places that they were at, they said, if we start now, building this is probably an 8 to 10 year process for us. And so they wanted to accelerate that time frame. And so that initial decision is what drove the first part of the partnership. What we did with them is we sat down and we really mapped out a value-based journey for them. And we said, okay, here are all your existing contracts. What does it look like to evolve these agreements over a 5 year period, and taking on risk where appropriate to do so under these agreements? And what would that mean for you financially? And then what infrastructure and capabilities do we need to build to make sure you're performing under those contracts? So that was the initial part of our work. And that identified then a number of areas that we focused our attention on. You mentioned the physician enterprise. They have a large number of high-performing employed physicians, but we started there. The initial thought was, oh, we need to align their comp model to these value-based contracts. We pushed hard on that and said, let's not lead with the comp model. Let's lead with a cultural assessment of what does it mean to be an SSM employed physician? What are we really saying we want our physician group to stand for? And once we had alignment around that, what is the governance structure that we want to put in place to ensure that we're monitoring, that we're achieving the culture and the outcomes that we want to? And then it was at that point in time where we started to talk about a differentiated comp model. And it's served us very well in that we weren't leading with, oh, it's only about the economics of this. And, oh, physician, you need to put more of your compensation at risk because to drive incentives to align to these payer contracts. It came pretty naturally as a result of a definition of, okay, the SSM enterprise broadly is embracing value-based care. We on the physician enterprise as well need to do that. So that work didn't happen overnight. The cultural piece took a while. The comp model, I'm not going to say that's easy, even with the other work that we did, but it provided a context for it. Then you have to run the analysis around that, run a shadow comp model for a period of time so you understand the ins and outs of it. But that was an interesting journey for them on that part of the work. The other area, and I mentioned it before, we really spent a lot of time on their care management enterprise and ended up creating a joint venture between the two organizations that encompasses all their ambulatory care management resources. And we did a lot of what I talked about just a few minutes ago with them.
Yeah, super interesting. So I've got two threads I want to pull on from that. First being curious for your thoughts on what you think made SSM consider, value-based care or optimizing their performance like a strategic priority in bringing you guys in.
Yeah, it's pretty simple, Blake. They just think that's the future. They think it's the right thing to do from a stewardship perspective. They're very mission-driven organization. They think that focus is being on the right side of history around what's going on in the industry. And then it's hard to talk about them in kind of in one manner because each of their markets is so different. But there were opportunities in each of their markets to perform from a value-based care perspective in a little different way. St. Louis is more about pure payer relationships. Their Wisconsin market is more about an IDN, and the Oklahoma City market, Oklahoma is still primarily a fee-for-service market, but opportunities on that physician enterprise and on the quality contracting side. So they were really motivated by doing the right thing and felt like value-based care is really aligning them appropriately with the patients and with the industry broader of trying to do more and cost less.
Yeah, that's pretty impressive too from y'all's perspective that you're able to kind of flex your capabilities across three very disparate markets, right? Like they say healthcare is local and every market has different dynamics, and that's very interesting. The second thread I wanted to pull on was you mentioned a few things, especially around the physician enterprise. You talked about governance and culture, and then also physician comp change. So I'd love your perspective on like what you think drives those components or any other components that drive behavior change or optimize like alignment the most, or if it's, a combination of those or how they're kind of weighted in your mind.
Yeah, and make sure I answer your question. We've focused a lot on this. Navvis has a sister company, ESSA Health. And so that's a group here in St. Louis where we're headquartered, and we leverage their experience in value-based care. They've been taking full percent of premium risk in Medicare Advantage for a long time and have great quality and cost outcomes related to that. We came together and leveraged what ESSA was doing and what Navvis was doing and created what we called Surround Care Academy. There are 9 or 10 and growing modules that we have, and it's really focusing on there's a module around the business of healthcare. So most physicians, as they go through training, or if they're employed by a health system, the economics of what really drives the healthcare world, they're not attuned to that. And so there's a module that focuses on that. There's a module that focuses on what we call early disease recognition. So a lot of folks say, oh, we need to do risk coding. Well, why? What does that mean? And what behind that is really a disease state. And what are we doing to treat that disease state and trying to delay its onset? And so understanding both the economic and the clinical side of that, but those programs, and then there are some pure clinical related modules that we have as well. Those programs are delivered through a combination of faculty that we have, physicians that Navvis employs. We do pull in the ESSA physicians, and then we use a train the trainer model as well, where we're working with our partners in their markets to get folks to leverage the materials that we've developed. I say all of that, Blake, in that it's a much different approach that we've had great results on, where the physicians start to understand more about what their role is in this business of healthcare, because it is a business. They clearly get the clinical side of it, but they don't always understand what may be asked of them. And so creating kind of a common vocabulary and a literacy around the business of healthcare, we've had really good results. So let me give you a couple examples. One of the modules focuses on annual wellness visits. We had a number of physicians saying, well, why is that important? Why should I spend that extra time doing an AWV? And so educating them around what that means, what a successful annual wellness visit looks like, the information that can be captured from that, what that can mean as far as building out a care plan for that patient, setting the next time that they would come in. It's about context for the role that people play in a very, very complex system. Is that responsive to your question?
Yeah, absolutely. And what I'm hearing is kind of this through line is there's just a general need, both in healthcare more broadly, but like just for transparency around goals that the organization is setting. And so you guys are helping to, step up to the plate there and provide education and tooling and all those sorts of things to help the physicians understand like, hey, this is how this plays into my role. And, this is aimed at helping me and helping my organization more optimally, essentially. Is there anything you would add to that?
Yeah, I think that one of the interesting aspects of what we've learned through this journey is, and I hate to use adages, but I find myself doing it, but what gets measured gets managed. And there is no doubt that shining the spotlight on patient outcomes, on cost of care, on low value care, on how often patients are going to specialists, and showing that creating access for primary care physicians really does, it's from our perspective, getting these high cost, high risk patients into their primary care physician. I want to say that's secret sauce. It's not too secret, right? But it's very, very important. But setting up data and analytics and then reporting around those things with a common goalpost for what we're trying to achieve, that's been really, really important. And it then allows on a monthly basis, quarterly basis, a review of how are we doing, and then more importantly, what are the quality and the cost impacts related to that? And it's not that people aren't focused on those things or aren't doing those things, but we don't always get the patients who need it. We don't always get them to their physician unless we're very intentional about it.
That's super interesting. And one final question I have kind of on this physician side of the equation is I've talked to some other folks in the past, and I've heard this kind of theory around, hey, I don't think a ton can change in healthcare until the comp model changes, like physician compensation. I'm curious for your opinion on that. And then also, what is a physician's reaction to their compensation changing, from a RVU basis or whatever it is into something that's more, value based, if that makes sense?
So I would say to the comment that we're not going to get there without a comp change, there's power in that statement. There's no doubt that aligning incentives is really important, but all incentives aren't just financial incentives. But it is important. So I think that some people refer to it as the last mile, right? That we can do everything that we can, but we need that physician's buy-in. And I think a financial alignment around a contract is very powerful, but also can be a little dangerous, right? So take an independent physician that is just operating under a Medicare Advantage full risk arrangement. They are clearly economically aligned around performing under that contract. But how they do it, the quality programs that they can put in place, that's where I think a health system has an advantage. So again, providing the context for the physicians, showing them how they're performing from a quality perspective or an outcome perspective vis-a-vis their peers. And most physicians will say, well, my patients are sicker. So kind of going one layer deeper and talking about, the acuity index or the disease burden that different panels of that physicians have, and showing that, well, there is a big variance in care, but the acuity of your patients isn't that different. So how can we talk about that? Because physicians aren't out there saying they want to provide low value care. That's not who they are. They want to provide high value care, but they don't always know whether it's high value or low value. So I think the comp model is important, but I wouldn't even use the term necessary but insufficient because I think as long as you can engage the physicians and you can inform them, you can get pretty darn far around this path of sustainable change.
Something that I feel like is a through line throughout our conversation is this kind of, just greater need for transparency around, different parts of the physician or health system enterprise, like they say, another adage. I'll join you in our adages, but the communication is the key to success, right? It's like a very, very central theme in healthcare. I want to pivot over a little bit to, maybe some new emerging programs, a few emerging programs, all of which affect health systems in one way or another, and the work that you do. So obviously, CMMI has been pretty active lately. It seems like there's been this kind of resurgence in programs and interest around risk models, but also mandatory bundled payments within hospitals and health systems. So I'd love your thoughts around, how health systems should respond to lead, to access, to the bundled payments. Like, what does all this kind of mean, and how would you kind of tackle this as a health system kind of getting their feet wet in these areas?
There's no doubt that it's unsettling to the industry. but I'm not sure that's a bad thing. In all honesty, you can see everything that I've heard from the CMMI folks. I think their heart is in the right place, and I'll give you my bias so you can take that into account as you hear what I'm about to say. I'm a believer that in the healthcare space, as far as payment innovation, it's going to come out of the government. I think DRGs came from CMS, and I think that we are ultimately going to get material, broad-based, both commercial and governmental payment models adopted out of something that the government does. Before I talk about each of the programs individually, I will tell you the advice that we're giving folks, that there's, in our mind, there's no doubt, if you look at the demographics of our aging population, you look at the demographics of how sick those people are and the sicker that they're getting, you understand the economics of what percent of every governmental dollar is spent on healthcare, that something has to change. It's not sustainable. So is a mandatory CJRX program the right thing to do? I kind of like it, but even if it's not, the conversation we have is, let's not focus on the payment models so much, because they may change over time, and we'll do in-depth analysis to understand the implications of those. But there are certain things that are never going to change and that you will always get rewarded for. And that is taking care of your high-risk, high-cost patients, understanding what it means to navigate patients through the system. So how are you manage length of stay within your acute setting? How are you managing transitions of care, hopefully to the home when appropriate? But if it is to a post-acute provider, then how are you managing the length of stay there? How are you engaging your physicians around that work so they understand what the goal is? There are a core set of principles, Blake, that we feel, irrespective of the model, that you will ultimately get rewarded for. So building capabilities across those areas, I don't think is ever going to be out of vogue. Then when LEAD comes along, and you talk to a lot of people, very, very interesting program. I think CMMI has done a lot there to try to address some of the questions or criticisms that's been out there related to just the MSSP ACO program. But it's tricky, right? The analysis that we've done for all of our customers show that based on what we know right now, and there's more to come from CMMI, very few of our customers are going to move to LEAD. There's too many questions related to it. But when you look at attributes of what is in that model, I have no doubt that it's going to continue to get better because they've identified the right things. There's just some issues around benchmarking and the settlement mechanics that really are causing people to look at the economics and say, I know I need to be in these programs. They're not going away, but I'd rather stay in an enhanced track MSSP ACO at this point in time until we get a few more reps related to LEAD. So I don't know, is that responsive, Blake?
That's super helpful. And should the future of all these programs just be MSSP enhanced track? Like, what do you think should change in a future, risk program? Assuming like we want that to be the future of healthcare, like payment and financing, like what do you think needs to change?
Wow, that's a big question.
Maybe a little loaded there. I apologize.
But I love the magic wand. If I had the magic wand, what would it be? I do think shared accountability around cost and quality is really, really important in any model. I do also believe that you can't ask providers to take on more risk, and I think providers should be at risk for the care of their attributed patients. I really do. I think that drives alignment, but you can't ask them to do that without a line of sight as to how they can succeed in doing that. That otherwise they're going to continue in the fee-for-service world. So I say that to say I think the models and where we're headed, I think the mandatory nature of where we're headed is where we need to go. I think that if I were able to talk to the government folks, I would encourage them to continue to go that way. I would continue to say that you have to provide clarity around the model and not be tweaking it. So people will understand and then perform based on the model that you've given them. So set it up right, create the right incentives, and the industry will come to you. The moving the cheese under the models is difficult for people. And then you start to lose the trust that we will have. And then if you want to go mandatory, then you'll get a lot of pushback from the industry because they'll say, well, wait a minute, we're not even sure what we're signing up for here. But I think shared financial incentives around managing the total cost of care, a continued focus on quality programs. And I think that trying to drive a uniform set of quality measures across the various programs would be very helpful for the provider industry as well. It gets very difficult to manage 40 different quality metrics. And then people have a tendency to throw their hands up and just say, well, if I don't get paid those quality dollars, it's not such a big loss. I don't think we want to lose people that way. I think part of your question as well was, is it just one model? Is it the MSSP ACO? I'm not ready to go there yet. I do think, as I've heard Dr. Oz talk about keeping MA active, advancing the MSSP ACO program, I think that's very wise. And I think over time, there may be a winner, but I don't think we're there yet. So I think keeping a couple different irons in the fire and continuing to evolve those programs, I think that's wise on the government's part, because you do have providers who are very interested in that senior population and helping manage the outcomes from those folks, and then people who aren't as good at it. And so I think a couple different tracks are helpful so you don't lose part of the market.
Yeah, that's super interesting. I appreciate that response. And so I'm going to recap just a couple of things that I thought were interesting. It's around, you mentioned this concept of shared accountability, which makes a lot of sense, and that exists in MSSP. But then also, I think I'm of the opinion, and would be curious for yours, that the government will continue to create these mandatory programs just from a budgetary standpoint, the percentage of GDP and the cost containment measures and those sorts of things. So they'll kind of be forced to do that. So let's say, like, in this world, like, assuming mandatory models continue, where do you see health systems needing to invest? Like, where does capital go? Like, maybe not the inpatient MOB, but where does it go instead, if that makes sense?
Yeah, I think that you already see a big push in the health system world to appreciating the ambulatory side of what's going on. Today, I think Ascension announced that it's finalized its AmSurge acquisition. And so
that was announced today. There you go.
There's a really big bet that they made, a smart organization, and that's telling you where they think that's going. I think that on the health system side, investment comes from two areas. One is improving access. And I think that what does that mean? I think it's access to physicians, but I think it's access to services to support patients as well, maybe even in a non-clinical way, but who you're responsible for. So as you get more mandatory programs out of the government, more and more patients are involved in these programs. Their disease burden may be different, but a number of their needs, social, emotional, financial, will fall across the same spectrum. Now, how far the health systems can afford to go down that path is another question. But I think those access to support services, mental health services, what I would call light clinical services, social determinant type issues, I think that's where you'll see more health systems trying to get upstream. I'm sure we'll talk about it because everyone is the technology piece, but I really mean from an AI perspective. I think that while AI is not going to solve every problem, I do think there's going to need to be a continued investment in technology. And I think part of that technology will be AI that can interact with these patients, can track them. You have someone, within our organization, I've started to refer to FTAs. So an FTE, a full-time equivalent employee, Now I think we need to be thinking about full-time equivalent agents, and I've told people in our organization, start to draw your org chart and add your agents onto your org chart, because that's where we're headed. And I think having those capabilities that are almost infinitely scalable, run 24/7, never have a bad day, can show a ton of empathy to people, all the things that you've heard about. I think that there will be an investment needed in that side of the world as well.
Yeah, for sure. And, it wouldn't be a healthcare podcast without talking about healthcare AI, right? Maybe double clicking on that. You mentioned maybe some of your folks are working with agents, but where are you guys, and maybe even you personally, like where are you guys experimenting with AI? Where you find interesting use cases or successes? Would love to turn it over to you and hear more.
For our business specifically, it kind of falls into three buckets. Internally, what are we doing just to drive more efficiency and capacity across our functions, our finance team, all of those things. That's all under review and people experimenting with things, with a few agents, I think, now driving some material scale and efficiencies for us. So that's one bucket for us. The other is in our relationship with our customers, kind of our solution. What are we using AI for there? It's interesting, Blake. We have a number of different pilots going on, but we don't have anything at scale yet. But what we're learning is the development cycle, as you've heard, is so much different than it's been in the past. It's cheaper, it's quicker, it's more flexible. So our thought was, I love that Jim Collins analogy of he has the analogy of you shoot rifle shots to make sure that you're hitting the target before you shoot a cannon, right? So you're not going to shoot a cannonball hoping that you hit it, but shoot rifle shots so you can get sighted in. I feel like that's what we're doing right now in that part of our business. The third area, really helping our customers think about AI. It's everywhere, right? Some people ask, will there be AI winners or losers? I don't necessarily think that it'll be that defined, because now anyone who has Outlook or a Microsoft product, Copilot is sitting there for you. So there really aren't going to be the haves and the have-nots from ground zero with AI. Everyone's going to have experience with it. I think it's understanding how you can integrate it into your business is really going to be a differentiator for folks. So we're trying to, much like I described what we do on the technology side of optimizing platforms that our customers have, we're also helping them do that with the AI vendors that they either currently have as their EMR providers offering more AI related activity, or a third party that they may be contracting with around AI. So those are kind of the three buckets for us.
Yeah, that's great. I mean, the more I hear from you, the more I just hear that you guys really just want your partners to succeed. Like you guys are just a real partner to everyone you work with and kind of meeting them where they are. So that's cool to hear, everything from technology to fee for service, you guys are there. And maybe with that, would love to wrap up the podcast with two questions. One, future looking for Navvis, and then one personal. So future looking first is what can we expect from Navvis, maybe in the rest of 2026 and even beyond, as you guys, delve in everything from AI to, the full risk spectrum and ongoing, proposed new models and everything in between.
Yeah, make sure my answer is responsive, Blake. As we think about our business and what the future holds for us, the government program space is something we're going to stay very close to, both in the MSSP ACO world and in these, whether it's CJRX or TEAM or whatever else comes out. That we think there's going to be evolution in that space, and we want to be coming right alongside that. As far as our other parts of our business, I do see us wanting to continue to help and partner with organizations, but also get more directly involved with different payment models. There's some advantages to our partners where maybe we should own an ACO in a market and help them have an alternative for some of their physicians being able to go into an ACO. We wouldn't do it to compete with our customers, but to really provide another avenue or another option. So I think you'll see us showing up more in that space as well. Clearly, I would be remiss not to say that we will be, I like to use the term automation. AI has a stigma for some people. We will be automating more aspects of our business in what I think is a very, very exciting path for much quicker data integration, which means much quicker analytics that we can generate, insights that we can provide, and therefore interventions that we can drive in the market. And I think last thing I would say related to where we're headed, a lot of what I've described is going to be core to our business for a long time going forward. There is a lot of inefficiencies in the healthcare world. And so the things that I've talked about as far as aligning physicians, about transitions of care, about managing length of stay, those things are still going to be very much in vogue, and people are going to have to execute against those. And while technology will help with that, it's not going to do it all. So the ability to leverage our learning across the markets that we work in has been very valuable for us, because some markets are experiencing issues that come up or resolved. Then it pops up over here, and we can say, oh, we saw that, in this market, here's what we did related to it. So more of the same, I think, around that, of leveraging our footprint and our learnings across our different partners.
Yeah, that's awesome. It sounds like there's a ton of great opportunity for you guys ahead, and looking forward to following along with you guys in your journey. So very, very cool. Okay, Tim, final question for you. Somebody I ask everybody on every podcast at the end, and I just want to know, I'm gathering intel from all of the great leaders of the healthcare world. What is something that you've experienced, a piece of advice, a book from person that has fundamentally changed how you live your life?
Can I say two things, Blake?
Of course, there's no limit.
Going back to my comment on adages, I am a firm believer in the lead by example adage. And I mean that both personally and professionally. I think there is real power in your personal relationships, whether it's when you're establishing your friend group, whether it's you're raising kids, whether it's just it's you and your spouse, of leading by example. And then when you take that context into a corporate setting, I think it becomes that much more important. Being a leader is a gift. It's not a right for anyone. And so when you're given that gift, how do you really optimize and maximize that opportunity? I think it's by showing up every day and being the leader that you want other leaders to be. And I'm going to look at my whiteboard because I have it written up there. There's 5 words that we've adopted in the organization that I think embody this. It's respect. So we want everyone to be considerate. It's excellence. Be uncompromising in what we do. It's authenticity. You need to be very, very real with people. It's accountability. You have to be reliable. And the 5th one is compassion. You need to be caring. So I wrote that on my whiteboard. I look at it every day and try to live it. And when you do that, I think it becomes easier then to hold people accountable to that. So lead by example is clearly something, and I've been blessed in grandparents and parents who, I don't know if they would have used those terms, but for me, they lived it, as well as a number of other professional folks. Second thing that really has influenced me is this concept of the second curve. Ian Morrison has a book out about it. Charles Handy has talked about it in the past. And also, to me, this has applicability in personal life, my personal life, and my professional life. And the concept is, from a corporate setting, is companies are established, they grow, they mature, and then if you don't take action, they decline. And so the idea of creating a second curve that leverages where you're mature, your company is mature and before it declines, I think that's a really powerful concept. And when I apply it to my own life, I think about my professional journey, and it feels like every 7 or 8 years I was doing something different. I didn't even think about the second curve, but I think I was feeling that. It's like, okay, you've done this for a while. Is there something else that you want to do that holds your interest? From a company perspective, and it's what we do at Navvis all the time, is how do we think about what's next? What's around the corner? Where is this market leading? And how can we make sure that we're there and meeting our customers there or helping them get there? So those are, I appreciate the opportunity to talk about those, but two principles that really resonate with me.
Those are some incredibly thoughtful answers. And I can't help but think you're talking about leading by example. So I've got a 2.5-year-old, and I'll see him doing certain behaviors, whether it's like, shooing the dog away or whatever. And I'm like, why are you doing these things? And it's because he's seeing us do those things, And so it's the same thing just applied to adult humans, right? Where you're setting the tone for the organization. So they're very wise words. Tim, one more thing. I want to give somebody a shout out from your organization. You know Bob Bauer?
I do.
Okay. He has been reaching out to me for years. He's been a hospitalogist for some time. So I just want to shout him out real quick, just say thank you. And he sent me some helpful reports along the way. So sending him good vibes from the hospitology world. But other than that, Tim, thanks so much for your time today. I learned a lot from you, and wishing you guys success in 2026 and beyond.
Thanks, Blake. Great conversation. I appreciate your questions. It shows how knowledgeable you are about this really complicated area. So thank you, and thanks for everything you're doing.